out, this nodular scleritis is not going to go with steroids. Okay. IOL, as I told you, we can see the position of the IOL very well, the optic and the haptic. Of course, it's helpful in normal cataract surgery, but what in trauma? This is what happens. If you have an patient with IOL and undergoing a trauma, the IOL can be in any abnormal position that one can think of. You can see here that this haptic has come into the pupillary margin, optic has come out, this optic is into the pars plana region. So one can plan out actually before surgery what to do. These are the 4 different types of, positions of IOL which can happen in trauma. It can literally be anything. This IOL is in the anterior vitreous cavity, no relation to the zonules at all, no capsule seen. This is slight subluxation of the IOL. This is an obliquely placed IOL, and here you can see the IOL has almost gone into the anterior vitreous phases, come forward, and it's subluxated out. It gives us an idea before surgery as to what to anticipate. That's the reason to do. Another usefulness, the most important that we see, especially in old traumas, is when they come back with raised tension, is to see the presence of angle recession. Of course, gonioscopy can see angle recession very well. But if you want to document or if you want a further idea what it is, so for that, we need to see the scleral spur well. How do we mark the scleral spur? This is the ciliary body and this is the sclera. So you can see the difference in the echogenicity between the two. When the line severe trauma, you can see the anterior chamber over here. That's the supraciliary space which has fluid, and you can see the communication between these two. So it's case of cyclodialysis cleft. Again, a huge cleft that you can see here. That's the iris, there's the ciliary body, there's the sclera. You can see hyphema out here, continuing into the supraciliary space. The entire ciliary body is detached. That's a large supraciliary cleft. Again, that cleft can be marked out at which clock hour it is, and a peritoneal laser can be done, and I have done serial follow-ups whether that is helpful or not. Intraocular foreign bodies, I told you, can be present anywhere. This is a large foreign body lying over the iris, but they can be in the ciliary body, in the zonules, anywhere. If it is not seen on slit lamp and we still suspect it is somewhere there, we can do a UBM in addition to the B scan to see what is going on. Position of the lens, the last structure seen. We can have abnormal position of normal lens. We saw the abnormal position of IOLs. There's a large subluxated lens into the anterior chamber. You can see the zonules are totally stretched out here. Again, the stretching of the zonules, but they are not torn as yet, but the anterior and posterior capsule is intact. Now you can see the zonules being torn over here, and this is the probing of the anterior vitreous phase into the AC. So you can see even the vitreous coming out forward, obviously because of the torn zonules over here. And this was a large iridodialysis leading to zonular tear. One small string of zonule is still intact, but the capsule, lens has been subluxated temporarily, but the anatomy is still maintained. The anterior posterior capsule are intact. He showed me a case of Marfan's. This is what happens in Marfan's. The zonules get stretched out, but they are still not torn. You can see it intact. I got this to show the difference between the two. Whereas in this case, you can see complete tear of the zonules with rupture of the anterior capsule, but the posterior capsule is still intact. Again, rupture of the zonules. We got another case where the lens was subluxated, and we wanted to know from which clock to which clock hour it is seen here. You can see the zonules being stretched out one place and torn at the other place. And then we use what is called the 20 megahertz probe, which is somewhere between the UBM and the posterior, the 10 megahertz for the posterior segment, to get a complete view of the lens and the anterior segment. This probably sees it much better than the UBM. I'll show you in the next example. The posterior capsule is seen much better with the 20 megahertz probe. You can see a posterior polar cataract with the posterior capsule here. You can see a traumatic cataract, but the posterior capsule is intact. Here, a traumatic cataract with posterior lenticuloconus, but the posterior capsule is still intact. The last slide, I stopped it out with a very interesting case of the usefulness of seeing the posterior capsule and its what happened. This was a homeopathic doctor and his wife, both homeopath. They came home on a motorcycle. Probably somebody must have heard of this before, or somebody must have operated this case. He came home on a motorcycle with some foreign body sensation in the eye. So the wife said, okay, fine, let me have a look. So she put a torch and said, kuch to bhi safed safed dikhta hai. So something was there on the cornea. She said, don't go to the ophthalmologist, we'll remove it, don't worry. He tried splashing water, nothing came out. So then she came out with a brilliant idea. She took a 10 cc syringe, filled it up with saline. She said, I'll flush the foreign body out. While doing that, the needle came off of the syringe, went through the anterior and the posterior capsule. Through the pupillary margin, you can see it's gone through the capsule substance. The posterior capsule is ruptured, lens matter in the anterior vitreous. Fortunately, the needle stayed here. The needle was pulled out, and it is he's undergone a surgery and he's fine right now. Okay, what is the use of UBM in the?
Woke everybody up.
I've been asked this question very often. When can we do a UBM? If you have any doubt of there being an open wound or there being don't do UBM. It's absolutely contraindicated because we fill it up with saline, everything, it's not required. It's difficult to do in acute traumas because patient is uncomfortable. Now we have the anterior OCT, it gives us some idea at least over there. It gives us a complete anterior segment anatomy for a definite treatment and should be combined with a 10 and 20 megahertz probe. It cannot be used alone. Thank you very much.
Thank you, Deepak.
The advent of consumer forum cases, for all the injuries case and all things. In one case, I remember in Andhra, the consumer forum judge was asking, has ultrasound been taken or not? Because ultrasound has been taken, the verdict came against the doctor. So this is one of the importance of ultrasound in the evidence-based medicine and in the court cases also.
Dr. Yogesh Shukla, the presentation is on unusual cases of ocular trauma.
Good afternoon, everybody. Dr. Rao can deduct half a minute from this talk. You see, in 2012, India is hosting the World Ocular Trauma Congress. We have a International Society of Ocular Trauma, and in 2012, the next conference, Ocular Trauma Congress, and the Ocular Trauma Society of India.
You deserve it, sir. Congratulations.
So, I was, if you remember, I was also the organizing secretary of the 2009 AIVS conference at Jaipur. So, having that faith in me, the OTSI has given me the privilege to hold it at Jaipur. So, I take this opportunity, the house is full, so I take this opportunity to invite you all for 2012 at Jaipur. Please.
Thank you. We'll all come there.
You are all welcome.
Dates of the conference?
Yeah, there is a poster which has been already put by Dr. Natarajan outside, which depicts the dates also. It is 7th and 8th October 2012. 7th and 8th October. That's a very nice season for all the international faculty also, Indian also. I would also just take a minute, just a few seconds. This year I am contesting for joint treasurer in the forthcoming IIFS elections at Ahmedabad. So I need not to say your help is. Now, I'll show you some cases which are slightly unusual, as I thought I should show it to you. In fact, tomorrow we are having the executive meeting, and I would be putting the proposal to have a session on some unusual cases presentation of ocular trauma. There could be a panel who would, there could be unusual cases, and the panel would discuss, and it would be open to the house. So, people, the younger ophthalmologists who have difficulty in managing those cases can understand and can have the know-how. Now, this is a boy who came with a blunt trauma by a cricket ball. We can have a point.
It is there.
This patient had a, you can see there is a hyphema here about grade 1 maybe, and there's a big iris tear here, and this corneal edema. After a few days again, because I keep on seeing them after every 3 days, because though we have a busy outdoor, but these trauma patients, because I am a pediatric ophthalmologist, so I keep on calling them and I keep a tap on them. So he came to me after 3 days, and the hypopema was still there, and you could see multiple iris tears here. You see the sphincter tears are all around. This is still a corneal edema. It has come after 1 week. You can see still a small clot of hypopema still there, not completely resolved. There is a large, mydriasis, probably, paralysis of the sphincter muscle and all that. This is the corneal edema after 15 days. After 1 month, the patient showed a beautiful cataract, the subcapsular rosette-shaped cataract he had. This is again after 1.5 months, approximately the same time. The patient still had a clot here. The cornea has cleared quite a lot. Here you can see the sphincter tears are still there, but the patient still had hypopema and the pressure shot up to 50. The patient was continuously monitored. You can still see number of, the iris atrophy here, the multiple areas of iris atrophy, sphincter tears, still mydriasis, this beautiful subcapsular cataract here, corneal tears. And then after 2 months, we put him on heavy hypotensive agents. He was put on everything. He was put on acetazolamide, he was put on brimondine and all that, what we could do, and the pressure remained normal, 17, 16 for about a month. We weaned him on from the hypotensive drugs. The patient maintained normal pressure for about a month.